Okay, checking circulation and shock. Now then, so let's define normocardia, brady and tachycardia. Well, your normocardia is 70 to 80, brady is 50 and tachy is 100. So there's some quite nice round numbers. Textbook blood pressure site, your biceps brachii, find that. Brachial artery left arm with the sphig. Etymology of sphig, so sphygmo means pulse, and manometer means a pressure reader. Theory for how it works, so you inflate the cuff, right, until your brachial is occluded, and that's normally about 30 mils of mercury higher than usual systolic blood pressure. So you should be seeing it cut off at 150, because obviously SBP normally is 120, but obviously if patients are coming to you, white coat syndrome, hypertensive, it can go up to 180 plus, can't it? So SBP is the first spurt heard as it begins to deflate, right? So you've occluded it completely, keep going, keep going, keep going, and then the SBP is what breaks through, bang, and then you keep hearing these Korotokov sounds, and then the diastolic blood pressure is when it's too faint to hear. So when those Korotokov sounds end, that's it, right? Korotokov sounds. I'm probably pronouncing it wrong. So what is pulse pressure? Now your pulse pressure is your difference between systolic and diastolic. So if it was 120 over 80, it's usually 40, right? So you can sort of think that. So when you hear the SBP spurt through, even if that's not 120, even if that's 150, 160, 170, you can be like, right, I'm assuming that when we get 40-ish down, I'll stop hearing it. So as soon as you know SBP, you can start to really think, right. 8 locations to take a pulse. Your classic 8, so you've got your superficial temporal in the head, and that is medial to the ear. You've got your facial, which is mandible, mouth by the corners there. You've got your common carotid artery, lateral to the larynx. Remember that your common carotid artery bifurcates at C4 at the superior level of the thyroid cartilage, superior border. Appendicularly, you obviously got your brachial, medial to biceps brachii. Radial, lateral wrist. Femoral, inferior to the inguinal ligament. Your popliteal is posterior to the knee, and then we all know dorsalis pedis. So define shock. There's my shock emoji. So it's the failure of the cardiovascular system to deliver to meet metabolic demand. So we get not enough supply, not enough shit being removed. We're going into anaerobic respiration. That fermentation is changing pyruvate from those cellular respiratory cycles into lactic acid and other toxin accumulation, and that's widespread organ dysfunction. We can broadly, there are a lot of ways to classify shock and a lot of subcategories, but here are Tortora's, as of 2017, 4 good ways to classify: hypervolemic, cardiogenic, vascular, and obstructive. Sounds just, it's nice and easy. Hypervolemic, there's not enough blood, right? Cardiogenic, problems with the heart, so arrhythmias, valvular malfunctions, MI. Vascular, speaks for itself. Obstructive speaks for itself. So your common cause of hypervolemic shock will be a hemorrhage, acute trauma, AAA, loss of fluids. Your cardiogenic shock will usually be MI, so CO decreases. Like I said, valvular, excessive preload, afterload, contractility impairment, arrhythmias. Anything heart-centered, issues with the heart that affect that cardiac output, that stroke volume. Vascular shock is inappropriate vasomotor response. So you've got 3 big categories here: an anaphylactic response, so loads of immune things are being released, loads of vascular spasms and changes, boom. Neurogenic response, so the vasomotor brainstem centers and the medulla are sending off aberrant signals, so vasomotor is inappropriate. And then, of course, the big one that you've got is septic shock, so coming from the bacterial toxins affecting vasomotor. So this could easily be called vasomotor shock, basically. How bad is septic shock? 100,000 killed in the US per annum. Most common cause of obstructive shock, PE, nice and easy. And the body's goal in response to shock should come as no surprise to you: return cardiac output and arterial blood pressure to normal. It's about reversing the lack of supply to organs. Shock is the body going into shock because of toxins accumulating, because metabolism ticks on, but it's not getting enough fuel and the sewage pipes aren't clearing the waste. That's what causes the shock. You need adequate cardiac output and blood pressure to return it to normal. So that comes from RAS, ADH, sympathetic nervous system upregulation, and localized vasodilators. So when is shock life-threatening? When volume drops below 10 to 20%. At that point, none of the previous mechanisms, sympathetic drive, RAS, ADH, none of these things, local mediators, is going to save you. Symptoms of shock. So in the heart, it's less than 90 mils of mercury. Weak tachycardia because it's heavily stimulated with adrenaline, but not a lot of volume output. Fluids, clammy, pale skin, reduced urine output, high thirst, acidosis due to the lactic acid buildup. In the head, you've got a decreased loss of consciousness, and we're diverting from the GI tract, so we have a lot of nausea involved. So the news system, as of 2012, there's a news 2 coming out, but let's stick to news 1 for now because it hasn't been approved. This is NICE as of 2016. So lungs, respiratory rate above 25, oxygen sats below 91. So although we're hyperventilating, we are becoming hypoxic at that rate, aren't we? Heart rate, systolic blood pressure is less than 90, pulse rate is greater than 130. Again, sympathetic nervous system upregulation from the cardiovascular centre of the medulla oblongata isn't sufficient. Heat, temperature is up with all of this work that's going on. Decrease might be unresponsive only to voice, there might be total loss of consciousness there. So a quick sort of summary. Respiratory rate greater than 25, O2 sats of less than 91, that's the lungs, and then we've got the 3 H's. So you could think of it as like, look here, the news, right? So lungs, heart, heat, head. Lungs, heart, heat, head. So we're breathing a lot, our pulse is high, oxygen sats are low, blood pressure's low. So despite our best efforts, we're not pumping enough fluid, we're not getting enough oxygen, unresponsive maybe only to the voice, and temperature's up. The sepsis 6 is what you do when you suspect those things, right? So LHHH, you're starting to think, something septic going on here. What is the sepsis 6? So 6 key immediate interventions in suspected sepsis. So your 3 interventions and then 3 things to investigate further. So give high flow oxygen, IV antibiotics, and IV fluids. And you can see why. Remember that quite often we can have less than 91 O2 sats. A lot of those things, it could be septic shock. If it's septic shock, it's bacterial toxins. Fluid addresses hypovolemic shock. Okay? And then in terms of testing, we're doing HB and lactate levels, which is again quite obvious. Hourly urine output. We've said that urine retention is occurring because ADH is quite high, right? Blood cultures to find that infective source, right? So we've got the sepsis 6 to deal with a news. High flow oxygen, IV antibiotics, IV fluids, HB and lactate levels, urine output hourly, and find that source. And there's a summary. Thank you very much.